All right, I think the waiting room is cleared up, so I think we're ready to take it away. Michelle, we'll hand it over to you.
Great, thanks, David. Good morning, everyone. My name is Michelle Probert. I use she, her pronouns, and I'm the director for the Office of MaineCare Services. I am excited to welcome you all to our second annual consultation with our MaineCare Rate Reform Technical Advisory Panel to inform our schedule of rate determinations for the forthcoming calendar year. I just came back from Washington, D.C., where I was at a National Association of Medicaid Directors conference. Last year at that conference, we actually received a national award for the rate reform work that we are doing. And it's pretty exciting that through the good work of this group and many others internally and externally to the department, other states are starting to copy what we have done. So Rhode Island is in process. New Mexico learned from us in some of their own rate reform efforts. Alaska really wants to talk to us now, as does North Carolina. So it's good when you're starting a trend, especially in a space as complex as Medicaid, where we know how very important having a good reimbursement system is to the health of providers and, more importantly, to the health of the members that we serve. So I will run through high level the agenda, and we will have our top members, advisory panel members, give introductions, and then I will turn it over to Mandy Lee to let everybody know how today will go. So we're going to give everybody a bit of a recap of Public Law 2021, Chapter 639, which governs our efforts. We are going to talk about the goals of MaineCare's rate determination schedule, as well as rate system reform generally. We will go through a review of accomplishments to date, legislation that is driving some of our efforts, and then go into our recommendations for the calendar year 2024 schedule, as well as acknowledge the services that we still need to get to beyond what we are recommending for calendar year 2024. And then we will pause specifically to take questions and comments from the technical advisory panel. And then time providing, there will be opportunity for public comment also. So with that, if you can show the next slide, we'll put this up here really briefly and then actually take it back down, because it's nicer to do introductions when you can see people's faces. So I will just go down through my list. Is Karen Lee Harrington here? I'm not seeing her off the top, so we'll circle back to see if she joins. Marty? And if you could say who you are, as well as the organization that you represent. Oops, we are not hearing you, Marty. Okay, maybe, Marty, if you want to say who you are in the chat while you're working. You weren't muted, but no sound was coming through. All right, Joan.
Can you hear me? Excellent.
Yes.
Hi, everyone. My name is Joan Cohen, and I am the Deputy Commissioner at the Department of Professional and Financial Regulation. For the purposes of this meeting, that would include the Office of Professional and Occupational Regulation and the affiliated healthcare boards. Just briefly, health licensing boards are neutral on the issue of billing and do not have jurisdiction on the issues of reimbursement. So that to the extent there are questions of any licensing board, I'm here as a coordinator to share those questions with the appropriate licensing board. Thank you.
Thank you, Joan. And do we have Heather Hyatt here from the Division of Licensing and Certification?
No, she wasn't able to make it.
Okay, thanks, Mandy.
Welcome.
Meg?
Morning, I'm Meg Garrett-Reed. I'm the Executive Director of the Office of Affordable Healthcare. We're quite a new state agency and independent state agency tasked with tracking and analyzing health spending in the state and proposing solutions to the legislature to improve affordability and access for consumers.
Great, thanks, Meg. Meg's position was not filled yet at this time last year, so we are very happy in the state of Maine to have a functioning Office of Affordable Healthcare now with Meg at its helm, and happy to have her on this panel as well. Okay, Mark.
Good morning. I'm Mark McInerney, Director of the Center for Workforce Research and Information at the Department of Labor. Here to try to provide expertise around available data on labor markets and other economic data to support these efforts.
Thank you, Mark. Nice to see you. And Amanda.
Good morning. I'm Amanda Rector. I'm the Maine State Economist. I'm in the Department of Administrative and Financial Services, and I provide the sort of big picture economic outlook.
Thank you, Amanda. Nice to see you as well. We'll try Marty one more time to see if her audio is working, and otherwise I can introduce her. Nope. All right, so Marty is a life and health actuary with the professional and financial regulation under the Bureau of Insurance. And Marty, if you're not able to get your audio working, I just invite you to actively use the chat to share any comments or questions. And also, I'm not seeing currently Harrington yet. Mandy, do you know if she was planning to attend?
Yes, she did accept. Yep.
Okay. All right. Well, hopefully she's just running a little bit late. All right. So with that, I will turn it to Mandy to talk about logistics for the meeting. Thanks.
Thank you, Michelle. So my name's Amanda Lee, and I'm the rate setting coordinator for MaineCare. My co-host today is Jessica Lebesque. Before we begin the presentation, I wanted to go over the details of the public forum, including how to submit comments at the end of the forum. First, you may have noticed that participants are in listen-only mode and the chat function has been disabled. You can only message the co-hosts, but because I'm running the slides, if you do have messages or questions, please send those to Jessica Lebesque's attention. In order to make a comment, when that time comes, internet users will raise their virtual hand by selecting the controls at the bottom of your screen and then selecting the raise hand from several options that appear inside the participants panel. You may also raise or lower your hand using the Alt+Y key on your keyboard. Telephone users will raise their hand by pressing *9 on your phone. We ask that you leave your hands raised until we can call on you. Once the comment period begins, we will call the name or telephone number of the participant and ask you to unmute your line, which will appear for internet users as a visual prompt on your screen. Telephone users will hear a recorded voice that prompts you to unmute by pressing *6. Once unmuted, please begin your comment by stating your first and last name, title, and the organization you represent, or your affiliation, for example, if you are a member, a guardian, or interested stakeholder. Please try to keep your comments to 3 minutes to give everyone an opportunity to comment. And then after the conclusion of your comment, please remember to lower your hand. This forum in its entirety is being recorded via Zoom, and after today's forum, we will transcribe all the comments and save the recording on our secure server. And then at the very end of the forum, once the forum today concludes, there is a public, a written comment period, and we ask that written comments be submitted to my attention at amanda.lee@maine.gov by November 14th. And that will be shared in a notice, as well as at the end of the call, we'll go over that again. I think that's it. I think we're ready to get started.
Thanks, Mandy. I did realize that I neglected to introduce our state staff, so we should do that as well. David, would you like to start?
Sure. Thanks, Michelle. I'm David Jorgensen. I'm the Director of Data Analytics and Rate Setting for MaineCare. Mandy's already introduced herself. Mandy's on the rate setting team, and Jessica is also on the rate setting team. Jessica, would you like to give a quick intro?
Hi, I'm Jessica Levesque. I am a project manager, rate reform analyst on the rate setting team. Kristen?
Thanks, Jess. Hi, everyone. I'm Kristen Merrill. I am the current acting policy director for MaineCare Services. I use she, her pronouns. Nice to see everyone.
All right, I think we're good. David, I'll turn it to you.
Yeah, so just wanted to spend a minute on our Chapter 639 public law. This is the legislation that is really the legislative framework that drives how MaineCare structures our rate system reform and our rate determination processes. One of the requirements, number one today, is setting an annual schedule for public review and comment, and this schedule is developed in consultation with the technical advisory panel joining us today. I'll go into a little bit more detail on that in the next slide, but I will just mention a new requirement that wasn't in the original legislation was that every 5 years will be we're basically working on a 5-year cycle to get through all of the rate determinations. And so if you have a rate determination in 2023, then 5 years from now in 2028 would be the time frame to be up for another rate determination. A couple standards that this legislation sets is that we look at relevant state and national data. This includes Medicare benchmarks. This includes other state Medicaid benchmarks, and also commercial reimbursement benchmarks when appropriate. There are different standards developed for the stakeholder engagement process, making sure that we're reaching out to relevant stakeholders, presenting our information publicly, and creating clear documentation of those conversations. And we have our rate reform website, which we'll share at the end of this presentation, where a lot of that documentation and the public meeting recordings are posted up there as well. It also established the rate system subcommittee of the MaineCare Advisory Committee, and Mandy is our liaison to that committee as well. And it establishes the technical advisory panel. So relevant to today, we will be consulting with the technical advisory panel on the proposed rate determination schedule for the next calendar year for 2024. And after this meeting, we will be sharing the proposed schedule to our website, that rate reform website, and we'll be taking public comments at the end of this meeting, as well as in writing by email. After that comment period is concluded, we'll post a summary of those comments alongside the proposed schedule and any adjustments that we might make to the schedule based on the comments. But of note, we are allowed to also conduct off-schedule rate determinations when appropriate. If something unexpected arises that needs to take priority, then we can definitely add those in if they weren't originally added to that schedule. So this is the basic timeframes that we'll use in the development and finalization of this schedule. So I won't read through every single bullet, but I'll just note that we have extended the public comment deadline through mid-November, and that will allow the rate system subcommittee to have an opportunity to discuss and to also present any recommendations to the larger full group of the MaineCare Advisory Committee, so that if that discussion is beneficial for developing comments or questions, then we'll allow that time so that you can get those developed before that November 14th deadline. We would like to finalize the schedule by the end of November. Obviously, Thanksgiving holiday poses some scheduling challenges, but we think that it will be doable to have everything finalized by that week of November 27th. And Michelle, this one is back to you.
Yes, thank you, David. So I'm sure there is some awareness that we are building the plane while we are flying it, but not only that, but we are also trying to get on a regular maintenance schedule and have the infrastructure for that maintenance schedule at the same time, so that not too far in the distant future, we will be able to just focus on flying the plane with good maintenance without having to do too many things at once. So another way of saying that is Chapter 639 really focuses on the principles for rate reform, including how to ensure that services receive sustainable reimbursement. But in order to get to that point, first we need to make sure that we get through all of our services and bring them up to what we informally refer to as baseline. I think many of you are aware that we began our rate reform efforts before Chapter 639 passed, because we recognized that the situation was too serious to wait. As a result, I would say that we have made some great investments in the system earlier on, but also some of those investments did not meet all the criteria or the principles of our new law, since that law did not exist yet. So I will talk through some of our accomplishments prior to Chapter 639, recognizing that those did not always meet the full intent of the law. And so when we are able to circle back to those services, we will make sure at that time that our efforts do meet all of the requirements of Chapter 639. I will also note that we have lots of sections of MaineCare policy. Within those sections of policy, which are essentially kind of like a health plan's benefit manual, right, of covered services. Sometimes a section of policy is really about a single service or a very small scope of services. Sometimes a section of policy is really a whole range of services for a certain population. And one of our principles is that where we have like services across multiple sections of policy, we really endeavor to address those services at the same time, because it makes sense to have the same payment approach and oftentimes amount when we're dealing with the same kind of services. That is not always easy to achieve, because for every section of policy, we have to go through rulemaking and and get federal authority as well. So that can be a lot of work on our end. But again, we think that it is really worth it so that we are not treating different providers of the same service differently. And then, really overarching everything is the fact that we are trying to make sure that our reimbursement methods and rates are data-driven, that they are adequate and reasonable, and also equitable. Maine is not alone in the fact that around reimbursement, decisions get made, sometimes for very good reason at the moment that they are made, but sometimes those decisions stay in policy for over a decade, and the reason that made sense for certain differentiation of rates or special treatment at one point don't necessarily make sense 10 years later. But if nobody has a regular process for reassessing those decisions, then they just get kind of baked into law, and that can often lead to further inequity in a system. And as we go through this work and are really trying to get all services to baseline, it's always it's a challenge. On one hand, we obviously need to keep pace with legislation and budget initiatives, and on the other hand, we're trying to keep an eye on we may have touched this certain service multiple times for these reasons, and we haven't gotten to another one yet, and trying to balance workload and requirements so that we can get to all services in an equitable manner. Okay, so thank you, Mandy. I'm not going to read through these in detail, but I do think that it is worthwhile to remind all of us of the work that we have achieved, and I will be focusing on the work that we actually achieved prior to Chapter 639. So we made investments in a number of HCBS services, as well as personal care services. Some of those were based on rate determinations. Some of those were associated with the law that we refer to in shorthand as Part Quadruple A, which requires that the labor components of rates equal at least 125% of minimum wage. For those first two rows, I will note that those multiple efforts did not address nursing clinical therapy services under those sections of policy, unless there were circumstances where it was appropriate to make Part Quadruple A adjustments for some of those services. And then our children's residential care facilities, sometimes known as PNMIDs or private non-medical institution appendix Ds, were addressed as well. Therapeutic foster care services are a part of that section of policy, and we are working on that rate determination presently. We also have really aligned our reimbursement for ambulance services with Medicare. However, there are non-Medicare codes that remain to be addressed. As I think folks are aware, we went through a broad effort with dental services that aligns with our expansion to adult dental coverage, but we adjusted rates for both adult and children's dental, and took what I think is a pretty I don't know if it's wholly unique, but I have not heard of another effort in other states where we explicitly benchmarked commercial rates for those services where commercial rate was available and appropriate. And because that is a benchmark methodology, but it is not a Medicare benchmark, in Chapter 639, it states that services that are benchmarked to non-Medicare amounts need to be updated every 2 years. So we have that work underway also. There's a long list of sections of policy, which for the most part mirror services that are covered under Medicare as well. And we went through a Medicare standardization effort where we really brought the benchmark up to current year and also standardized what that looks like. Similar to the first row, there are non-Medicare codes in those sections of policy that still need to be addressed. And lastly, our Maine Mom or maternal opioid use program. We also went through the rate determination process for that important program prior to 639. So these are not full rate determination efforts, but I just wanted to note that in addition to full rate studies, there have been a number of other efforts to strengthen our system and also to work towards having regular adjustments that help the system to be sustainable. So I already mentioned, here's the full citation, the Public Law 2021, Chapter 398, Part Quadruple A, regarding the 125% of minimum wage benchmark. And then you can also see the many services where we implemented a cost of living adjustment, again, prior to Chapter 639. And this gets into more current work. So I'll pause to see if there are any questions or comments related to that content so far. All right, I'll turn it back to David. Thanks.
Michelle. So one of the features of our rate system reform and Chapter 639 is that we do provide the annual cost of living adjustments to services where the rate was determined by a benchmark that isn't updated annually or a rate study. So these are some of the cost of living adjustments that we've provided since Chapter 639 went live. We've made it a practice for the most part to try to align our cost of living adjustments to be consistent across sections of policy. Some of these sections of policy are subject to that Part Quadruple A requirement that aligns our reimbursement with minimum wage adjustments. So every January 1st, we do need to give those COLAs to those sections when minimum wage changes. And in this year, this January, minimum wage went up by 8.24%. So that is the COLA that we established for those sections of policy that are subject to that Quadruple A provision. But to be consistent with other sections of policy, we kept that 8.24% COLA and applied that to other sections of policy in July when they were due for their cost of living adjustments. And then nursing facilities and residential care facilities are a little bit more complex because they are both subject to that Part Quadruple A, but there is also a legislated cost of living adjustment specified in legislation with its own index that requires it to be somewhat different than just the minimum wage adjustments. So in January, we did make an adjustment to a Part Quadruple A add-on that addresses that minimum wage adjustment component of their rate. And then in July, we applied a cost of living adjustment based on the CPI index for nursing home and adult daycare services. All right, and this is on to Kristen.
Thanks, David. So this slide identifies legislation that was included in calendar year 23 reform efforts. So most of these reform efforts identified here were pursuant to budgets and budget initiatives. So I'd note that several of these were found in Maine Public Law 2021, Chapter 635. And you'll see that that includes Section 107, psychiatric residential treatment facilities, or commonly referred to as PRTFs. Section 93, opioid health homes, commonly referred to as OHH. And sections 45 and 46 specifically for our psychiatric hospital services. You can also note that there are a few references to Public Law 2023, Chapter 412. This is primarily for the HCBS lifespan efforts, and Section 97, Appendix D, known as the Children's Residential Care Facilities, specifically for the therapeutic foster care services. Our palliative care efforts were a result of a budget initiative, as well as work through the American Rescue Plan Act of 2021. We commonly refer to this as Section 9817 authority. And then you can also see for Section 23, developmental and behavioral health clinic services, there was statutory requirements under 22 MRSA, Section 4063A3, which directed the department to provide reimbursement and adopt routine technical rules for foster care comprehensive health assessments. I think that covers all of those sections. Does anybody have any questions? Okay. I think I'll hand it back to David.
Thanks, Kristen. We wanted to kind of share what a rate determination might look like. Every rate determination is a little bit different because every service is a little bit different. Every provider group is a little bit different. And the rate determination process depends to some extent based on whether it's a rate study where we conduct provider surveys to gather relevant cost and staffing data, or if it's a benchmarking analysis where the data collection is more about gathering those benchmarks than it is about surveying providers. And there are also different intensities of research that we need to do with our service model definition or design. Some services are very well standardized, very clear and straightforward, and others require us to make some decisions about exactly how we want to structure the service model, and that can have implications for the reimbursement model. So we've tried to reflect that service model definition and design as kind of a parallel process. We like to start that work well before the rate determination starts. But there may be sometimes a continuation of that process and some back and forth, some feedback between the rate model and the service model as we really try to nail down what those assumptions are. This is kind of a prototypical process. Not every step will feature as prominently for every rate determination, but these are the typical steps that a stakeholder would anticipate the department taking on in the course of a rate determination. I see Meg has raised her hand. Yeah, Meg.
Yeah, just a clarifying question, David. So the rulemaking that appears here, would that typically be the result of a need to clarify the definition of the service as opposed to being related to the rate setting for that service?
Yeah, Kristen, would you like to take that question?
Sure. It could be. It could be the need to redefine service components, service models. It could also include adjustments to our reimbursement sections, further defining those as well. And sometimes we've found through previous efforts that there is also the need for clarification on for practitioner levels and their investment in each individual service model. So it could be a range of changes to any given rulemaking.
Okay, thank you.
And I'll also just note that the rulemaking doesn't really necessarily follow rate implementation. It's hard to create a flow chart that shows some overlapping or variable timeframes. So the goal is to, at the very least, start the rulemaking before rates are implemented. But depending on schedules, that can get a little bit tricky. I do see we have one more comment. Christy?
Hi, yeah, so I noticed that, I mean, it talks a lot about data collection, and having gone through this with Section 65 within this last year or so. I guess I found, and just wanted to give this feedback, and I'm not sure, I guess, how best to navigate it. So I think one thing that we notice is that the rate determination, when you're doing this process, takes into consideration agencies' current costs and reimbursement. In doing so, it may not necessarily be reflective of what's actually needed from an organization. And so what it often means, I mean, no one's functioning on a negative budget, right? You no longer survive. And so it's not necessarily a super accurate reflection of what an agency truly needs to run the costs of its organization, and often may result in, for example, staffing not receiving market adjustments, benefits not being on par and competitive from a recruitment and retainment standpoint. And so as we drill down at this, unfortunately, agencies continue to struggle ongoing, because obviously what's not there, right? What's supposedly hidden in a budget. Now, I also understand your side of the coin, right? Because you're like, well, that's all the information I have to go on. So if you're functioning at that, then I'm going to assume that you can continue to function that way. So I guess I just wanted to put forth some of the realities and the concerns. And I know at one point, many years ago, maybe a decade ago, there was actually even a consideration of decreasing the rate for Section 65. And so I guess I just worry, in the climate of ongoing need and not enough provider resource, we have less and less people coming into this work. And so those are just things that I guess I wanted to put forth in terms of perspective that I've seen and having gone through the process. I also want to say, and I probably should have started with this, I didn't do a good sandwich model here. I appreciate the fact that, number one, there was a rate increase. So thank you. Number two, that this is obviously a very structured process. I appreciate you looking at it on a regular basis, as you are, because I do think, years and years, we have to give people sort of raises, right? But if we don't have rate increases, it's very difficult ongoing to continue to do that. So I do want to express gratitude for that. I think the other piece of this, just further sort of thoughts about it and input, with the new rate determination, there was no longer a discrepancy between independent practitioners and agencies. However, agencies continue to hold the requirement of having to go through licensing processes and the added expense, staffing resource, and just overall burden of that. And so you're reimbursing an independent practitioner in private practice the same as an agency, without them having the same sort of oversight and burdens therein. So I guess I just wanted to put out some of the factors that we experienced through this, if those are to be considered in further kind of considerations as it comes to rate increases.
Thank you for your comments, Christy. They're definitely very much appreciated. I I slipped when I called on you. Apologies, that was my fault. We do hope to hold comments to the end and focus on the discussion with the technical advisory panel.
I apologize.
No worries. I was the one who called on you. But we appreciate those comments, and we'll take those down. All right, I think we will move on to an update on progress on our calendar year 23 rate determination schedule. There has been a lot going on this past year, so we want to take some time to recognize what's been accomplished so far. We have sections 2 and 26 were part of a rate study together for adult family care homes and day health services. Those rates were increased in January of this year. And that rate increase also satisfied that Part Quadruple A requirement for 125% of minimum wage. We did also do rate increases for Section 13, along with 17, 28, 65, and 92 altogether. Also implemented on January 1st, and not all of the services were subject to Part Quadruple A, but many of them were. So we made those effective on that January 1st schedule. We'll pause for just a second because Karen Harrington was just able to join. Karen Lee, we did some introductions earlier, so if you don't mind, we'll ask you to give a quick introduction of yourself.
Good morning, everybody. My apologies, I'm late. My name is Karen Lee Harrington, and I work with the Maine Health Data Organization and the Maine Quality Forum. And again, apologies, I'm late.
Thanks, Karen Lee. We're happy to have you. All right, next slide, please, Mandy. Thank you. A couple other accomplishments in calendar year 23. We have updated our DME reimbursement to equal 100% of current year Medicare rates. Our reimbursement was previously based on I think like 2009, whatever a very old Medicare rate, and was not being updated annually. So this was a significant change for DME providers. We have established rates for a new National Diabetes Prevention Program. Those rates are not live yet. They're still pending adoption, but it's great to have those established. We have rebased our FQHCs, and we have just launched some rates for our acute psych units and our acute substance use disorder units, the inpatient units, moving from a rate per discharge to a DRG based rate that also has a length of stay adjustment, so that those significantly more acute cases can have additional reimbursement that's reflected in that higher acuity level and that additional length of stay. So those rates were just implemented at the beginning of this month, but will be retroactive to July 1st.
And I'll just note, just back on that previous slide, the previous reimbursement for the DME was based on 2011 Medicare.
Thanks, Kristen.
Yep.
With all of those accomplishments, we do still have quite a bit of work on our plates that's ongoing. from our current year schedule. This includes updating the rates for psychiatric residential treatment facilities. There are currently no providers enrolled in the state of Maine in MaineCare, and we hope that with updating our reimbursement methodology, we'll be able to bring some PRTFs into the state and have that available as an additional level of care for our residents here. The Section 23 service that Kristen mentioned earlier for foster care comprehensive health assessments, we have established a rate for that, and we're just working on finalizing that draft rate. On the foster care note, we're also addressing our therapeutic foster care service that's currently under Section 97, Appendix D. We hope to split that out of Section 97, and we're also going to be adding a new level of care, a therapeutic intensive home service model to that as well. So those rates we're currently finalizing draft rates. We still need to engage in our first public forum presenting those draft rates. Under Section 30, family planning agencies, we're working on developing an APM and also updating fee-for-service rates. Crisis mobile response teams is also, I think we're close to setting a date for a public forum for those as well. And then our long-term care reform is a very large effort, looking at our reimbursement for nursing facilities and residential care facilities. There's been our current reimbursement is pretty complex and administratively burdensome on providers and on the state, and we're looking at ways to improve that process as well as making sure that we're setting appropriate reimbursement rates, rewarding providers who provide higher quality, and making sure there are incentives for cost controls as well as quality, and on top of easing that administrative burden. Also ongoing, while we've just updated those rates for the distinct psychiatric units and distinct SUD units, there is broader work going on for hospital reimbursement reform. We have been dividing this into more the acute hospital side and then the psychiatric hospital side. Psychiatric hospitals are also sometimes referred to as IMDs. That's Spring Harbor and Acadia hospitals. So we're looking at hospitals across the board. There are inpatient services, outpatient services, rehab services. All of that is still underway. CCBHCs, Certified Community Behavioral Health Clinics, are a brand new model that we are looking to stand up. And there's a lot of service model development going on in that CCBHC world as well, and the rate model development is closely following that service model development work. In Section 93, opioid health homes, That section was stood up originally focusing on opioid use disorder, and we think it's appropriate to bring other substance use disorders into that same model. So we'll be looking to create additional services more appropriate for other substance use disorders. And then 2 more projects currently in service model design, palliative care and community paramedicine are underway, and we, I think, may be able to start the rate determination portion of at least one of these before the end of the year, but we're still looking at right around the end of the year to really dive in wholeheartedly to that rate determination work. And then I think lastly, for work that's currently underway, we have just launched with the Office of Aging and Disability Services the rate determination for a new waiver, for the lifespan waiver. That rate determination will also include any services that exist under current waivers that are similar to the services in the lifespan waiver. So that will impact sections 18, 20, and much more significantly, sections 21 and 29. Before I move on to the upcoming work, Michelle or Kristen, do you any other words on the current work underway?
I'll just foreshadow a slide that you have upcoming that gives a visual of how tremendous that work is in scope from a dollars perspective. And in addition to the dollars, it's also complex.
Yeah, absolutely. All right, next slide, thank you. So there are 3 more rate determinations that we are kicking off before the end of the year. Our Primary Care Plus program, while that has already been launched, there is a phase 2 that needs to be initiated, and we are still working through the procurement to secure a vendor for that work. But once that has been accomplished, we'll be diving wholeheartedly into that work in the next month or 2, hopefully in the next month. Home and community-based services, nursing, clinical, and care coordination services. We are currently still developing the RFP for that to get a vendor on board to do that work with us. And then dental, this is a rebasing of those benchmarks that Michelle mentioned earlier, pulling the commercial data from MHDO and using those commercial reimbursement benchmarks to update our reimbursement for dental. All right, moving into 2024. I think I will hand it over to Kristen to speak to the legislation.
Thanks, David. So as David mentioned, this is some legislation informing our work for calendar year 24 reform schedule. So as with the previous slide I discussed, this again includes work resulting from budgets. So that includes specifically coordinated specialty care and the new Section 65 service, which we refer to as multidimensional family therapy, or MDFT. We will talk in some upcoming slides a little bit more in detail about what those services entail. In addition to those, we do have some school-based health center services and early intervention work upcoming. That was a result of Maine Public Law 2021, Chapter 227, which was an act to ensure continued health-related services for children to access their education. And some folks might know that as LD 854. That's really it. Does anybody have any questions about the legislation or the budgets? Okay. I'll hand it back over to David.
Thank you. So I won't read through everything on this slide, but we wanted to reflect as we discuss our 2024 schedule that there is a lot of work carrying over from the current 2023 schedule. So while we do hope to wrap a few things up before the end of the year, a lot of this work will continue. Most significantly, on this slide, I think the long-term care reform and hospital reform are both very large and complex. A lot of the other services listed here are new services, and while they may not reflect as much spending or may not reflect any current spending currently because they don't exist yet, standing up a new service is also quite complex. Next slide, please. And also continuing into the next year, the HCBS work related to lifespan, as well as the HCBS nursing, clinical, and care coordination work will be very large efforts. And I guess I won't read through all of these. I'll just reiterate that there's a mix of new services here and some large complex services that need to be addressed. So for new work that we hope to initiate in 2024, with the legislation that Kristen called out, we're looking to initiate the work on the school-based health center services, the coordinated specialty care, and multidimensional family therapy are the three studies that we hope to kick off the rate determination work within calendar year 24. And then I also wanted to reflect PNMI E and F here. We think there's a lot of service model definition work that will need to happen with our sister agencies, the Office of Behavioral Health and the Office of Aging and Disability Services, to really define what these models are, to figure out if we need to create a different tiered structure for this model, or there's just a lot of variation in the services and the types of services, the population served that these models address, and developing a single reimbursement model for that variety of services and populations will be fairly difficult. So we're hoping to spend quite a bit of time on that service model definition within the next year to really have that stronger baseline to work from as we move into that the reimbursement model definition. All right, Kristen.
Thanks, David. So in the next few slides, we'll just talk about a little bit more in depth the upcoming work related to essentially what we've already discussed in terms of reform efforts. So this slide focuses primarily on our HCBS lifespan and sections 18, 20, 21, and 29. So section 18 is home and community-based services for adults with brain injury. Section 20 is our home and community-based services for adults with other related conditions. Section 21 is home and community-based benefits for adults with intellectual disabilities or autism spectrum disorder. And section 29 are support services for adults with intellectual disabilities or autism spectrum disorder as well. And so this study includes services related to employment, community, and home supports. So as you can see on the slide, there are a number of previous reviews and rate studies that have impacted services in these sections. And those include rate studies performed by contracted entity known as Burns & Associates back in 2015, as well as 2020. And those studies included services under 18, 20, 21, and 29 as well. I'm not going to read the entirety of the rationale, but you can see the effort is pursuant to Public Law 2023, Chapter 412, which again is budget, as discussed previously. And this effort really does focus in on those employment, community, and home supports. The priority rate for the evaluation, as noted, state fiscal year 24 or later. And this effort is really a joint effort between Office of MaineCare, Office of Aging and Disability Services, and Office of Child and Family Services to work on those transition needs for individuals with IDD or autism or other disabilities as they transition through their various stages of life. Folks have any questions? Okay. Not seeing any hands. Thanks, Mandy. You can move on to the next slide. So our next effort is for section 106, school-based health center services and early intervention. Folks might already be familiar with what MaineCare refers to as section 106. But this ultimately includes new services that will contain requirements surrounding school health related services. This will be a new section of the MaineCare Benefits Manual, and this is a major substantive rule, which means we do need to, when we propose it, it'll go in front of the legislature, get review. These services include preventative, diagnostic, and therapeutic services. You'll also see note for basic laboratory services as well. And as noted previously, this is pursuant to Maine Public Law 2021, Chapter 227, which essentially just required us to adopt reimbursement and rules related to services for children, specifically for children ages 0 to 5, in order to access their education. Because this is new, there are no known or existing methodology rates identified at this time. Our next slide focuses on multi-dimensional family therapy. You'll hear us refer to it as MDFT. So this model is a treatment program. It serves adolescents and young adults with substance use, delinquency, mental health, academic, vocational, and emotional problems. The national program does consist of 3 stages of treatment that includes development of treatment plans, interventions, and reinforcement and completion of that program. This model does include parent, guardian, or parental figure participation in the program. And we do not have, this is a brand new service under Section 65 Behavioral Health Services, so we don't have any rate methodology or previous rates identified. This is also included as part of the Children's Behavioral Health Services plan that MaineCare currently has, and is slated for January 1 of 2025. This again was a result of a budget initiative, or a budget rather. Any questions? Okay. Our next service identified is coordinated specialty care. Sometimes you'll hear us refer to it as CSC. This service is an evidence-based treatment program. It's targeted for youth and youth adults ages 14 to 35. These individuals experiencing first episode psychosis or early serious mental illness symptoms, so ESMI. Core activities can include cognitive and behavioral psychotherapy, medication management, family education and supports, service coordination, case management, supported employment, and education. The funding for implementation of the service was, again, part of a budget. And as you can see, again, this is another new service, so we don't have any existing rate methodology or rates identified. You can also note that this was part of a previous LD 647 that did not pass, but was rolled into Public Law 2021, Chapter 398. Any questions? Not seeing any hands. Okay, I think I'll pass that back over to David.
Thanks, Kristen. We just wanted to share this slide to kind of show the scope of current work underway, and these darker squares here don't even capture that full scope of work that's currently underway. This is really just 3 rate studies, the long-term care reform, hospital reform, and then lifespan and related waivers services. Those 3 studies combined make up about 2/3 of our claims-based spending, or non-pharmacy claims spending. So this is really a huge piece of the MaineCare portfolio of services is reflected in the work currently underway. And that's not even recognizing that, you know, we're also looking at new services that won't even be reflected on this graph that shows current spending. While we're only looking for a few services to add in calendar year 24, we wanted to make it obvious just how much work is currently underway with regard to the current rate studies and the scope of services involved. I'm going to move through some of the other slides pretty quickly so that we can get to some discussion and comments. There are services we have on our radar that have not had a rate determination yet, that have also not made it on the current schedule. So those services are listed here. And in the next couple of slides, I won't walk through all of them, but this will be made, this will be shared publicly. We'll just call out that we have made updates to the sections where we benchmark MaineCare reimbursement, but there are some codes where there is not a corresponding MaineCare rate, and we do want to address those as well. But otherwise, I will take the opportunity to pause and ask the technical advisory panel if you have any questions, comments about what has been proposed for the upcoming calendar year 2024 schedule. Mandy, I think you can stop screen sharing for the moment. Thank you.
This is Meg. I think just looking at that scope and the significance, especially of hospital and home and community-based services and PNMIs. So there's carryover, I think, from 23 in addition to more services being considered in 24. Is the goal, and I'm sorry if I missed this when you said it, completing all that by the end of calendar year 24, or do you anticipate any sort of run over into 25, just because it does seem like a really significant amount of services to be considering in a calendar year?
Yeah, I think there are a variety of implementation dates targeted. We're targeting like July 1st for much of the hospital reimbursement reform, but there will likely be pieces of that that extend beyond. Long-term care reform has been targeted for January of 2025. The lifespan waiver, I believe, is targeting April of 2025. So there are a variety of implementation dates, and the rate determinations may really extend into 2025, especially for the work that we're initiating in 24.
Thanks, that's helpful. I think the only other thing I'd say, I wasn't as aware of the sort of broader strategy for this, and I think the concept of addressing like services at the same time, just wanted to sort of voice my support for that. I think that makes a lot of sense, both from sort of a capacity and workload angle, as well as ensuring, sort of like schedule across services that might be alternatives for an individual with a particular health need. So just wanted to, encourage that and say, I think that that's a really sensible way to address the timing.
Thanks, Meg.
I may have missed the specifics, but is there a set implementation timeframe for the Section 97? What is the timeframe expected?
Is this for the long-term care reform that PNMI sees?
No, I'm talking about Appendix F rate reform.
And I'll just break in for a moment to just, we want to make sure, and if I know some people have been coming on throughout, so you might have missed this at the beginning, but we want to make sure that our top members have finished any comments or questions, and then we'll move into public comment space.
Thanks, Michelle.
Okay, so members of the TAP, feel free to share comments or questions if you have them coming up, and also encourage you to interface where it makes sense with comments from the public as well. And I will just, related to the last question, I will say that the intent of this session is not to review specific implementation deadlines and projections. It is tricky business, especially for rate determinations that have not yet begun, to predict when things will happen. And we have our goals, but the work is complex, and then there are many factors. So we really want to focus today on the work that we are proposing to initiate in calendar year 24. Rather than going service by service to say when precisely we think new rates would go live. I get that that is frustrating, but it may be more frustrating for us to say one thing and then for that not to end up being true.
All right, thanks. As a reminder, if you do have a question or a comment, please raise your hand and we'll call on you in order. We'll start with Christine.
Just so I guess I understand a little bit further. So it sounds like rate determinations will be made every 5 years for each specific service. Is that accurate?
Yes.
And then I guess,
sorry,
oh,
I just
go ahead,
want to talk about that a little bit differently because right now we are working through all of our MaineCare services to do what I'll call a baseline rate determination. And once a full rate determination under Chapter 639 has occurred, then there is a 5-year rebasing schedule, if that makes sense.
I guess and I think you sort of described this, Michelle, at the beginning. You're like, we're building the plane while we're flying it. And I guess like, as I think about that, so I feel like we're catching up, right? Which is fantastic. And then on the other hand, I'm sort of like within those 5 years, we're continuing to look at like cost of living. And so it almost feels like, it feels a little bit like we're never going to catch up unless it starts to get to a place where cost of living can be ascertained on a more yearly basis. But looking at your spreadsheet of all the services, that would be pretty monumental unless you just sort of set a standard percentage to each service every year in that respect. So I guess I was sort of just curious about like any thoughts regarding that piece, because obviously like 5 years in the meantime, cost of living is going up for all these agencies regardless. And then there's no rate increase in that respect. Now, granted, I don't want to like kick a gift horse in the mouth here, because I think the other side of the coin is I like to have this structure in place, and I appreciate all the effort and administrative energy that's going into it.
David, do you want to speak to that?
Apologies, I got distracted by a separate comment in the chat. Could you?
You can do it too, David. That's fine. So I want to be clear that there's 2 things that are going on. One is, or well, probably more than 2 things. One, we're getting all services to baseline. Once there's been a full rate determination, then every 5 years there will be a rebasing. And when we say rebasing, it's really when you like go back into the assumptions of the model and say, are these assumptions still true? Which ones, like wages, for example, we know we need to update. And so it's a more comprehensive look. But part of Chapter 639 also calls for, in the interim years when we are not doing a full rebasing, there are cost of living adjustments. And so there are intended to be annual cost of living adjustments every year with a full rebasing done on a 5-year schedule.
And when is the cost of living piece starting to get looked at in the grand scheme of the plan?
We have been looking at it and implementing them, and also for services where we haven't been able to get to a full rate determination yet, we've been providing cost of living adjustments just in recognition that, time is passing, costs are increasing.
Life is happening.
Yeah, and so we do not do all cost of living adjustments at the same time because frankly, we just can't handle that workload all at the same time. And so right now, they are kind of split between January 1 and July 1 adjustments. And for the most part, and anyone on my team, correct me if I'm getting anything wrong, but the services that are tied to the Part Quadruple A, 125% of minimum wage provisions, there's a statutory requirement for a January 1 adjustment for those services. So, and there are a lot of them. And so like most of those services, or all of them potentially, are a January 1 adjustment. And then we look to July for the others. And so there's no hard and fast rule, but we're trying in part to manage our workload so that we can actually make all of those adjustments with our staff.
Thank you. I appreciate that, Michelle.
And I will also say, and this is in the statute itself, but because again, we're trying to manage the workload, et cetera, we say that a full 12 months at least needs to have passed for a service that has had a full rate determination to then get a cost of living adjustment. So for some services, it might be exactly 12 months. For some services, it could be 15 months because we can't, we can't handle all the rate determinations at once, or excuse me, all the COLA adjustments at once. We also can't handle having COLA adjustments like every month based on when a rate determination was completed.
Well, and an annual makes sense, right? Like I think about my annual val. That's when, the performance increase happens. So the same would be true for us. So thank you.
All right. Thanks, Christy. I think Laura, you're up next.
Good morning. I'm here with two hats today. My name is Laura Cordes. I'm the Executive Director at the Maine Association for Community Service Providers, MACSB. We're an association of 100+ providers supporting children and adults with intellectual disabilities, autism spectrum disorders, other related conditions, brain injuries, for a whole host of services, some of which are, or many of which I should say, have been touched on today, sections 18, 20, 21, 29, section 50, section 97F, sections 28 and 65, which I think will be considered under the new section 106, as well as section 13. My other hat is as a member of the MaineCare Advisory Committee and chair of the Rate System Subcommittee, which was functioning under a similar name, but formalized under Chapter 639. And I'll start my remarks with my hat for the Rate System Subcommittee with just great thanks to Director Probert and your team for the tremendous amount of work that you have been doing to right the ship around rates with the transparency and accessibility to information and making sure that they're adequate and equitable across the board. It is, it's really been terrific over the last year to see some of that come to life. Two notable things, I would say, just the website and the information that's really accessible in one place for all stakeholders to go to. And I know you keep building on that, but it is really great to have one place. And I really applaud all the work that goes into making sure that's updated for folks. Secondly, Director Probert, your participation in the MAC with robust updates, Amanda's participation in the Rate System Subcommittee with regular updates and being at every meeting to answer questions and give the great progress that's being done, and take back questions and share if there's the ongoing frustrations about some things we haven't gotten to, which I know members and providers certainly care about, and the timing. I appreciate everything that's on your plate. I know in the interest of time, I know this isn't a dialogue, it's really a comment, so I will just put a couple things out and shift to some comments from MACSB. But, I do appreciate all the work that's gone into the COLAs. I understand under Chapter 639, there was an effort outlined that the department would be looking at establishing through rulemaking a COLA for this process. I know that has not negated COLAs being applied, but if that is something that is going through the TAP and will be part of rulemaking, understanding that the new timing, given everything that's on your plate, would be helpful for stakeholders. And I think for the items that are in the 2023 schedule. It's great to see, and I haven't been able to crosswalk, and I appreciate that we'll have the time to come back in the Rate System Subcommittee and comment through November 14th. But understanding, hopefully, that all those that you haven't gotten to are carried over in 2024. I noticed that PNMI 97F and D have been carried over for kind of a service analysis and definition. I know it's frustrating for providers who've been asking and see themselves in the 23, kind of anticipate that there would be something forthcoming at the end of the year, but knowing the status of that going into the next year as that schedule gets finalized will be great for providers to weigh in on that front. I'll switch over to my MAXB hat again on behalf of our provider association. I want to thank you all for your tremendous work. We had come before the TAP or within comment from last year on the schedule asking for rate determinations for section 21 and 29. They had not been looked at with provider specific data through a rate study in close to a decade. We were very pleased to see that included, attached to the analysis that needs to be done to set rates for the very similar services that will be created under the lifespan waiver, to be in place in 2025. Michelle, you said it was complex, and that is all caps. It certainly is for everyone involved, but I appreciate starting as soon as possible to look at that, because the idea is that we will have one system still going while we're lifting up another one. We won't take new MaineCare members on that, but being able to have those systems for the thousands of adults with disabilities and the providers and workers that are supporting them coexist is really necessary. So thank you for your efforts there. And I believe that's it. Thank you for the opportunity to comment today.
Thank you, Laura. We appreciate your comments.
All right, with that, I don't see any other hands raised, and we are at time. So I will ask Mandy, if you could just screen share the final slides. If you do have written comments that you would like to make, you can send those to Mandy to amanda.lee@maine.gov, and we will happily receive those and build those into our comment summary. Obviously, you do still have over a month to get those comments in. November 14th will be that comment deadline, and you are welcome to have those discussions through the MaineCare Advisory Committee, the rate subcommittee, or the full MaineCare Advisory Committee as well. Thank you, everybody, for your participation today. Extra thanks to our technical advisory panel for taking your time to come and provide your feedback and questions. We look forward to the comments, and we'll be in touch about all of the materials being posted on our website. All right, thanks again, everybody. Take care and have a great day.
Thank you.
Thank you.